Bismillah ar-Rahman ar-Rahim. Respectable chairpersons, my colleagues, ladies and gentlemen, Assalamu alaikum. First of all, I'm grateful to the organizers, especially Dr. Aftab and Chima Saab, who was continuously in touch with me, and Madam, who was regularly in touch to keep me active, and all the organizers. It's always a pleasure, let me tell you, कि जब मैं यहाँ भी आता हूँ तो ये नहीं कि मैं आपको सिखाता हूँ, मैं खुद भी सीखता हूँ, because you keep on adding to your knowledge by repeating. So सुनने वालों की ज़्यादा मेहरबानी कि आप जागते रहें और सुनते रहें. कुछ बुजुर्ग सोने की कोशिश कर रहे हैं तो उनको चाय दे दी जाए. The topic I was given, all the fetal anomalies. All the fetal anomalies will take 20 hours or maybe more than that. So it wasn't possible. So I thought I should select a small topic for you, and that is the lethal malformations, which are incompatible with life, and they are non-correctable. Once you diagnose that anomaly, the only answer to the treatment is termination of pregnancy. So this is very important and very crucial question. Sometimes the gynecologist straightforward ask me, is it viable? Is it not viable? So there are very important landmarks where you should decide it and commit it. Yes, this needs to be termination or this needs to be continued. I'll touch that area where I'll say this does not need to be continued and that needs termination of pregnancy. Now the next question is, when should we have the ultrasound? We all have heard normally it's 20 weeks ultrasound you should carry out. But let me assure you, these days, the first ultrasound in my experience, my observation, should be as early as possible. Once you get pregnant, in the next 2 to 3 weeks, you must have ultrasound if there is no history of spotting and bleeding or any complaint. Mild congestion of the pelvic vessels leads to discomfort. But the main purpose of the early ultrasound is, number one, location of gestational sac. That is very, very important because there is increased incidence of C-section. With the result, there is increased risk of new ectopic pregnancy that is known as C-section scar-mar ectopic pregnancy, which we frequently see. If we miss it in the later stages, comes in 3 forms. The ladies keep on bleeding, the ladies have placenta previa, the ladies have placenta accreta, increta, and percreta. And that can result sometimes in hysterectomy. And that is a life-threatening surgery at times because the ladies can bleed and needs 10 to 15 bottles. So to avoid all those things, you must have first ultrasound as early as possible, maybe 2 to 3 weeks after you miss the cycle. Location of the sac and ectopic pregnancy, because sometimes it ruptures, it leads to very disastrous conditions. Second thing is, if you diagnose the sac, what is the anomaly earliest? Again, I don't say it is the 20 weeks, it should be done by 11 weeks. And preferably transabdominal, followed by transvaginal if you want to know the details, which I'll share you in the areas. There's a new ultrasound introduced for the last few years, and that is known as genetic sonogram. If the lady is doing normal, no complaints, then don't go for 20 weeks, don't go for 11 weeks, then it's done in about 13 to 14 weeks. That is known as genetic sonogram, which you can diagnose more than 80 to 90% of the anomalies. So that is if you can wait for that. But my still experience is, please, first ultrasound should be done within 2 to 3 weeks after you miss the cycle to know the location. We call that dating scan. You may have periods, any date, we don't mind it, but unless until you are diagnosed by ultrasound, even we can tell you the date of conception and the date of confinement is decided today. You may have irregular cycles, especially in the young primary gravidas. So their cycles get varied. To miss a cycle does not qualify you to be pregnant. Please make sure. To miss a cycle doesn't qualify you to be pregnant. Now, what is anomaly? It is anatomical or structural abnormality present at birth. So genetic sonogram is, as I told you, is done at 14 weeks of pregnancy. Now, if I say we are doing at about 11 weeks, we all very much concerned for one anomaly, and that is a Down syndrome. What are the soft markers which can give you a hint to diagnose it and to confirm your findings? That is knuckle transcendency at the age of 11 weeks. At the age of 14 weeks onwards, then the knuckle fold. Knuckle transcendency less than 4 is better, less than 2 is the best. But if you got knuckle transcendency around 4 millimeter and there is no other soft marker, please get the verification because 4 millimeter is a cutoff point. Similarly, the other markers, short, middle phalanx of the fifth finger, intracardiac calcification, these are all seen at 14 weeks, but at 11 weeks, the most important sign is knuckle transcendency, which you can appreciate that. If you got a 3, can I request for these front lights to be switched off, ताकि आपको grace image बड़ा अच्छा नजर आएगा if I switch off the lights. Front light switch off कर सकते हैं if the administration is around. Ultrasound and radiology is always in the dark room to have the best contrast of the images. If you look at this image, there's a 3D image. You can do it on the 2D as well, but 2D is only recommended if you find 75% of the fetus in the sagittal view. यहाँ पे बहुत बड़ा catch point है कि sometimes amniotic membrane, it takes 16 weeks to fuse with the chorion. So you can overestimate your actual knuckle transcendency and you can wrongly diagnose it as a knuckle transcendency thickness increase. So the best is if you do the 3D ultrasound, you can measure the exact knuckle transcendency. In this case, it is 1.2 millimeter. That means it doesn't need any follow-up for that purpose. But this is one of the soft markers, which is very important. Other soft markers are, as I just listed and just showed you over there. Look at this place. There is a very important catch point. If you do the transabdominal ultrasound, that is the amniotic membrane. That is the amniotic membrane. Okay? This takes 16 weeks to fuse with the chorion. So what you can make a mistake, instead of this line, you can make this line thickness, which is more than 5 millimeter 11 weeks. So you will label it as a case of increased knuckle transcendency, suspicion of Down syndrome, while it is not. So the take-home message is please do the ultrasound at 11 weeks, preferably by transvaginal and not by transabdominal, because you can overestimate by measuring the wrong line, and that is the amniotic membrane. That is the chorion, that is the amniotic membrane, and that is the true knuckle transcendency. You can appreciate this here. So this is not the true line for the knuckle transcendency. Please go for the transvaginal ultrasound. But if you find knuckle transcendency, look at this, it's about 6.7 millimeter. That is very, very alarming. Don't ignore it. Even I don't say 4 millimeter, you should ignore it. But if you find a 6 millimeter knuckle transcendency at the age of 11 weeks, you must be looking for some other criteria. As I've just mentioned, look for the cardiac calcification, look at the renal sinuses, look at the femur, which is small, 8 days. Let me tell you one thing here. The nature is very symmetrical, very organized, very disciplined. All your 3 parameters, biparallel diameter, femur length, and abdominal circumference, they go hand to hand, light off. That means there's difference of less than 3 days in each parameter. You may be healthy lady, you may be tall lady, you may be rich lady, you may be poor lady, irrespective of your nutritional status, your social status, your physical status, all the 3 parameters, they go very close to each other with a difference of 3 to 4 days. All those differences with a tall lady, with a short lady, with a healthy lady, they only come manifested when they are more than 26, 27 weeks. So up to 24 weeks, 26 weeks, all the parameters are matching this. But if you find at this age, the femur length more than 6 days small, BPD की age आ गई 13 weeks, abdominal girth आ गया 13 weeks, and the femur is 11.4 weeks, your ear should stand up. Why the femur is small? So start worrying for that. And these days, still the most sensitive is the humerus. If you find more than 7 to 10 days, femur or humerus smaller than the BPD and the FSC, start thinking there is something wrong over there. And if you think this is knuckle transcendency more than 4 millimeter, what next? Should we let it go as such or no? Now the best thing is, let's go for chorionic villus sampling, which is done about 11 to 13 weeks. By 11, 13 weeks, you have developed the placenta tissue over there, and you can do the transabdominal. There you can see, I'm coming over here, right through the placenta tissue, you can do this biopsy, and that biopsy should be sufficient to do the diagnostic imaging for the Down syndrome. Not only depends upon the 21, 18, or 13, all those syndromes, all the chromosomal anomalies can be done here. Because if that is done and that says it is normal, even 4 millimeter is acceptable, because in some patients, 4 millimeter is taken as normal, subject to the confirmation by the CVS. Without that, no. But if the CVS says it is okay, then you can continue the pregnancy, but still have a follow-up regarding other malformations. Now, I'm just showing you 9 weeks. हमने कहा था 20 weeks. I'm showing you 9 weeks fetus. The moment you find the transabdominal ultrasound, I always go for transvaginal if I find a little change in my observation. Now look at this baby over there. There is large subcutaneous edema over there. You can see multicystic mass over there at the posterior part of the neck. That means a Turner syndrome, and Turner syndrome means multicystic area at the back of the neck and hydrops fetalis. You can see the fetal ascites, you can see subcutaneous edema, you can see the multicystic, even small. But this can be only visualized on TBS at 11 weeks or less than 11 weeks. Don't expect that to be at the transabdominal ultrasound, because there is thick skin, abdominal wall, there is a bladder, and all those things, they reduce the resolution of the image by transabdominal ultrasound. So you find these two things, this ascites, edema, and this cystic hygroma, it is incompatible with life. That is a Turner syndrome. So instead of continuing further, no need of any verification, that's more than enough. So this needs, again, termination. Look at the lady who is around 12 weeks of pregnant. On transabdominal, everything was okay, because she was a very hefty lady. So look at this subcutaneous edema. Look at the large, and look at the cystic area over there. So it is, again, not compatible with life. Look at this fold. She is around 17, 18 weeks, and the fold is 7.8 millimeter thick. In lucency, it was lucent. The fluid was there, the proteins were there. But once it become thick, it become a hypochic and solid line at the back of the neck of the fetus. And that is 7.4 millimeter. Again, it's a definite case of Down syndrome. Just to look for the heart, you can see the intracardiac calcifications. There's a normal heart. And then you can appreciate the calcification. Yes, these are all associated. If you find one anomaly, the risk, if you find the one positive finding, the risk of Down syndrome is 10%. If you find 2, that is 50%. If you find 3, that goes 90%. So once you find one anomaly, please look for other anomalies. अगर और भी ऐड होती जाएंगी, तो that will add to the sensitive diagnosis. Yes, you can decide on these basis. Similarly, you can see the ears. They are low set ears. There is another age criteria from it. जितनी इसकी length होगी, उतनी उसकी age होगी. Say it is about 15 millimeter. The age of the fetus should be 15 weeks of pregnancy. Similarly, look for the renal sinuses. Both the renal sinuses, they are prominent, it's about 6.2 millimeter. Normally, it should not be there. If it is isolated finding, you can ignore it. But if it is associated with knuckle transparency, it is associated with the knuckle fold, it is associated with the intracardiac calcification, then definitely this carries its own value, because this is adding to the more and more findings. Similarly, look for the choroidal cyst. Normally, isolated finding, you will appreciate it in 19 to 22 weeks. You can sometimes appreciate. If it is isolated, don't get panic, don't worry, just repeat it, and they dissolve and they disappear by 27, 28 weeks. But if it is associated with the findings, it has got the value. It can be one-sided, it can be two-sided, it can be as small as 3-4 millimeter, or it can be more than 5 to 6 millimeter. But if you find only isolated finding, nothing to worry, no tense, just wait for 3 to 4 weeks, it will disappear. Similarly, nasal bone. If you find a nasal bone more than 3 millimeter, it is acceptable. But there you see two findings. Number one, look at the frontal bossing. It's like this. Number two, there's walnut. And look at the 4D ultrasound image. There's a frontal bossing and there's a bridging of the nose that has gone deep down. So that is confirming and adding to your finding कि मैंने इसका decision क्या करना है. Sometimes, in addition to nasal bone, you can find this cleft lip and cleft palate. You can appreciate this solely frenulum in the center. There is right, left, bilateral, there is deficient, and you can see this hard palate downstairs. That's how the normal babies, they look like once you do the 3D, 4D ultrasound, high density images. You can appreciate that normal. But if you find this anomaly, even a 2D ultrasound, start looking, आपको नजर आना शुरू हो जाएगा. Look at this sagittal view of the fetus, and you can appreciate this tongue and this deficiency over. And in the 3D image, you can appreciate this deficiency of the middle part of the cleft lip. Turner syndrome, as I just shown you there, and that is how the findings on TVS, multicystic area over there, and there's knuckle fold, and this subcutaneous edema all over the body. Again, slightly larger and slightly bigger, ascites, bilateral periphery. There is a cystic hygroma over there. There is polyhydramnia, and there is ascites. All these findings are suggestive of Turner syndrome, and the gender is female. Sometimes you find the polyhydramnia. The only finding is the lady comes with a bigger tummy than it should be. कि पहले दो बच्चे ठीक थे, अब बड़ा हो गया. Let me tell you, all those atresias which are in the upper GIT, like esophagus, like duodenum and ileal, the first presentation is polyhydramnia. Rectal atresia, large atresias, they present very late. So if you find 26 weeks of age and this fetal, this massive ascites, polyhydramnia, start looking at two things. Do you find the stomach? If you don't find the stomach, the abdominal gut is small. Think of the esophagesia. But if you find the stomach, there is only one-sided cystic area, but you see this spine, there's a left-right bilateral and they connect with each other. That is a typical diagnostic sign of duodenatresia. इसे कहते हैं double bubble sign. एक इधर भी है, एक इधर भी है. So this is a duodenum, that is stomach, and that's a midline. So you find cystic area on either side, that's a diagnosis of duodenatresia. Now, once you find a twin pregnancy on early pregnancy, there are three types of twin pregnancy. Number one, dichorionic, diamniotic, the best of all the pregnancies. Monochorionic, diamniotic, still high risk. But if you find monochorionic, monoamniotic, 25% of these fetuses can have conjoined twins. So please very carefully look for what kind of pregnancy. Look at this image I'm just showing you. This is dichorion diamniotic. How do you say? That is 1% this fetus, 2% this fetus. So that is the best of all. Number two, you can appreciate this thick amniotic membrane dividing line, that is a lambda sign. So it's one of the best pregnancies, you can ask for it. But if you find a monochorionic, diamniotic, there's a risk of TT syndrome. But if you find a conjoined twins at the age of, LNP was 10th, and this is date ka ji iske upar aa rahi hai, maybe 8 weeks or 9 weeks pregnancy. You can appreciate over here that this is one head, this is second hand, and both the fetal abdomens, they are up completely facing each other. We call that omphalophagus. If the abdomen is fused, omphalophagus, thorax is fused, thoracopagus, head is fused, craniopagus. So there you can see they're twins, but they're fused together. Even at this stage, you can diagnose this is not compatible with life, so this needs termination of pregnancy. This was the first case I ever diagnosed in my practice, and that is back to something like 90 something, right? So this was a case who had twins pregnancy, and she was around 27, 28 weeks of pregnancy. You can find the one head here, you can find the second head here, and both the heads are fused together. So I labeled it as a twin pregnancy, dipropus. Head was fused, thorax was fused, neck was fused, thorax was fused, abdomen was fused, and the ischium was fused. So when you have got all the parts are fused, that is known as dipropus. So I diagnosed it at 2 o'clock in the daytime and went home. At midnight, I received a call from the SR कि 27 हफ्ते की प्रेगनेंसी है, खातून को पेन्स आ गई हैं, cervix ओपन हो गई है, but the baby is not coming out. This baby will never come out because this is not 27 weeks, 54 weeks of pregnancy, because both the fetus are fused together and there's a large bulk of it. So even if the cervical canal is opened up, wide open, this can be delivered. So then I talked to her, please look at my footnote, it is dipropus and this will not be delivered. This baby will only be delivered by C-section. Even if it is not compatible with life, but this is not to be delivered by normal transvaginal route. I went to the hospital in the midnight, I took this X-ray, and then this is a picture of the image of the baby. It's more than 35 years old, just to tell you. And this baby cannot be delivered by transvaginal route, even if she is 24 weeks of pregnant. You all know as practitioners that 24 weeks baby can easily be passed out. But this will not, because you multiply with 2 and that makes more than 56, 58 weeks, which is not practically possible. So double the size of the head. Similarly, another baby was having a head, large head, fetal head, okay? they were fused together, but the parts were separate. So जब आपको twin देखे तो please make sure one take home message is measure all the three parameters, BPD, abdomen and limbs separately, and try to make sure you can appreciate the membrane divided, because this is one of the very, very rare anomalies. Monochorionic, monoamniotic twin pregnancy is very rare. Why? Because once they're monochorionic, monoamniotic, there's a cord over there, and the risk of cord entanglement and the babies can die in utero much earlier. But if they go up to this place, 25% risk of fetal anomalies. So I diagnosed this case as a case of conjoined twins, and this is a craniopig. His head was fused. Abdomen was okay, femur was okay, all the limbs were okay, but the head was fused together. So please, this is your job to twins, दोनों को separate अपने head पर check करने. And look at this, okay? These are I was in Jinnah, something like 2,000 something. So both the heads were fused together at the top. So you can measure the limbs separately, upper limb separately, abdomen separately, but you can't measure the BPD separately. So please, once you find this case of twin pregnancy, आपने amniotic membranes वो देखनी है और आपने parameters separate note करने. That's very important take-home message. The most important diagnosis of 11 weeks pregnancy in the incompatible pregnancies is acrania. Please, this is a very important message कि अगर आप 11 हफ्ते पे 13 हफ्ते पे देखें तो TVS 100% करें, because this anomaly cannot be missed by even a small practitioner having 3 months of experience. Must appreciate the fetal scalp bones. 11 weeks पे बन जाती है, शक पड़ जाए 1 हफ्ते बाद दोबारा कर लीजिए. But if you miss by 11 weeks, 12 weeks, those of you who are sitting here as gynecologists, you know at the age of 20 weeks, if diagnosed, you end up with a hysterectomy. So this is not the anomaly which is compatible, it's 100% lethal. Number one, this is not the anomaly which cannot be diagnosed by 12 weeks of pregnancy. If you diagnose a 12 weeks pregnancy, you can easily terminate the pregnancy per vaginum. अगर आप 20 हफ्ते में जाके पता चलेगा polyhydramnion के साथ, तो she will have difficult to deliver vaginally because the baby doesn't have the head downwards. तो उस वक्त से बेहतर है hysterectomy जाने के बजाय आप इसको 11 हफ्ते. And this is a 100% diagnosis by 11 weeks or 13 weeks. If you miss it, then I do. So I take a message, always look for the calvarium bones. इसकी बन जाती हैं by 9.5 weeks पे. You can still wait for 11 weeks maximum, but 11 weeks पे आपको पूरी complete bone नजर आ जाएगी. And you can see this acrania. Acrania में और उसमें anencephaly में, there's difference. The first of all, it appears as acrania. This calvarial bone is absent, but the brain is there. तो ब्रेन के ऊपर आपको ecogenic line नजर नहीं आएगी. Sometimes after weeks or 10 days or maybe more than that, this brain gets wiped out by the amniotic fluid. So then you see a small spongy brain at the base, which is known as anencephaly. Both are incompatible with life. One take-home message here, all of you practicing doctors, if you got any a lady who is diabetic, please ask her to avoid pregnancy till the blood sugar level comes normal for at least 6 weeks. In a normal lady, the risk of anomaly is 2%. In a diabetic lady, it is 5 times more, that means 10%. So this acrania is one of the complications in a diabetic lady. So try to guide them. If she is a known case of diagnosed diabetes, she should control the diabetes before she plans to be pregnant. And once, after some time, there's a bigger pregnancy, you can appreciate this small spongy brain, but there's no calvarium at the top of it. And this is how it presents. The baby have got the polyhydramnia, the mouth is open, you just see the eyebrows, and afterwards you don't see the top of it. And that's how it's the skeletal X-ray, and that's how the photograph after this. Similarly, one of the incompatible is if you find a fetus with the oligohydramnia. There are 3 conditions. Like a kam ho gaya, like a khatam ho gaya. The first thing is agenesis of the kidneys. Number 2, she has leaked out altogether. History is very important. And number 3, she may be hypertensive. Now, uska Doppler pe bhi is okay. There is no history of leakage. Then think of the kidney agenesis. But if you in practice only see the urinary bladder present, let me assure you that baby is viable. अगर आप किडनी नजर भी नहीं आया और एक नजर आ भी गया या नहीं भी आया, but you can see appreciate the urinary bladder, don't label it as incompatible unless until it is totally complete agenesis. And the complete agenesis is there's like is absent. But there's other condition which is McElroy syndrome. You find the abdomen, large abdomen, and that is the kidneys are very much enlarged. She is just by 18 weeks old. Large kidney. Normally kidneys are as large as your age. If you are 20 weeks pregnant, the kidney length should be 20 millimeter. If you are 30 weeks pregnant, the kidney length should be 30 millimeter. If you appreciate here, the kidneys are double the length of the age. So that means she is 18 weeks pregnant and the kidneys are 3.6 centimeter. So once you find they are large echogenic kidneys, they are polycystic kidneys, and the associated finding is defect in the brain at the occipital, which is known as the encephalocele. If you find these two pathologies, large kidneys with encephalocele, this is incompatible with life. So this needs termination, and there's a history of such patients. They repeatedly become pregnant and they have same issues. So the best if you could do it by 13 weeks transvaginally and you can diagnose it. Look at the kidneys again, large kidneys. यहाँ जितने लोग बैठे हुए हैं इनके एवरेज किडनी के साइज 9 to 10 centimeter. Ladies के maximum 10, gents taller men they can have 11 centimeter. Look at this baby. She is 24 weeks pregnant. Okay. But abdominal girth is about 32 weeks, and the kidney size is 88 millimeters. That means of adult size kidneys in a baby who is barely 24 weeks pregnant. And there is a large defect and encephalocele. The brain जो herniate हो गया it can never put back. आपने मार्केट में देखा लड़ाइयाँ होती हैं, चाकू पेट पे लगा, intestines बाहर आ गई. They can go back and they can stitch it. Once the brain is out, it cannot be put back by any surgeon because that becomes a vestigial brain. So this is again incompatible with life. Midline defects, corpus callosum. Normally you can appreciate this very nicely, corpus callosum, and there is a midline interhumerus fissure. If you find it deficient, the only finding is dilatation of the lateral ventricles. मैं इसको ज़्यादा discuss करूँगा, but the day you find these posterior ventricles, lateral horn ventricles, they're minimally dilated. There's interfissure, but there's large dilated third ventricle which is raised over there. If you find that, that is agenesis of corpus callosum. There may be partial, there may be complete, depending upon the finding. But this is not incompatible unless until it is associated with the posterior line defect. You can find this anterior and the posterior. What do you find here? There is agenesis of the cerebellar vermis and the dilated fourth ventricle and dilatation of ventricle. Once you find these two anomalies, both are midline, anterior as well as posterior, this is incompatible with life. Similarly, Dandy-Walker syndrome, same here. You can appreciate large absent the cerebellar vermis. Caudal regression syndrome. Please start looking for things. आप सुन के जाएंगे देखेंगे आपको start looking on it. Caudal regression syndrome. Those ladies again who are diabetic, please, the spine should be surveyed from top to bottom. You must appreciate the iliac plates and the spine should go beyond that in normal patients. Again, the diabetic patients, they have a high risk of caudal regression syndrome, so they should be allowed to control their sugar before they plan pregnancy. Look at this spine over there. यहाँ पे आप spine आ रहे हैं. जो ही आपने, you can see the ribs. So these are dorsal spines. Immediately after dorsal spine, the lumbar spines are missing. So there is caudal regression syndrome. There is no spine downstairs. The maybe baby delivered normal, but this baby will have a lot of problems, genitourinary problems, walk problems. If you see the ultrasound, both the legs will be close to each other. Normally legs are away from each other because of sacrum. There is no sacrum, there is no lumbar spine. So this is caudal regression syndrome, incompatible with life. Again, you can appreciate here. हाँ जी, brain जब अल्ट्रासाउंड कर रहे हो तीन चीजें नोट कर. If you note these three things, your 95% neurotube defects are out. Number one, cavo septum pellucidum. Number two, atrium of the lateral ventricle and cisterna magna. If you find these three things intact, 95% of brain pathology are out. The most common anomaly which I see these days, every other day I see one patient who has been advised to go for termination pregnancy is hydrocephalus. So I just want to stress on that, which is hydrocephalus and how to measure it. Please make sure every day almost I get one lady who has been advised termination pregnancy because of hydrocephalus. Let me assure you, if you see the early stage of pregnancy, gradually we are growing up and up. If you see the early stage of pregnancy, the main bulk of the brain over there is choroidal tissue, which is echogenic. And the choroidal tissue has always got a ventricle, and there is a lateral wall ventricle. As you grow bigger, the choroid becomes smaller than the brain grows. What happens if you look at this patient? If you look at this patient, the most important thing is that bright line is a choroid, and this is the outer line lateral wall lateral ventricle. If you appreciate this brain hypokaria, normally the brain is sonolucent by the age of 26 weeks. Why? Because there are less nuclei Over the time, the nuclei are increasing. As the nuclei are increasing, it becomes like this. It becomes like this. It becomes like this. It becomes. Otherwise, this is the early stages of pregnancy, 24, 26 weeks. The brain is sonolucent. तो आपको लेबल क्या दिया जा रहा है कि this is a case of hydrocephalus advanced termination. Please, this is not the area to measure. Where you should measure is very important. You should measure this area. There's lateral ventricle and there's inner valve. Medial lateral ventricle के दरमियान choroid है. You must measure on this area, not this area. It is maybe 11 millimeter, but there's a normal brain. So please make sure hydrocephalus unnecessarily reported leading to termination pregnancy is not recommended. But if you want to be in the lateral ventricle, you can appreciate this brain tissue, small peripheral brain tissue, grossly dilated ventricles. जब ये हो तो फिर आपने lateral ventricle ratio निकालनी है. How much is the ventricles and how much is the brain? If it is more than 50%, the mortality is more than 50%. But there you appreciate maybe 1/10 of the brain, 90% is the ventricle. So that means LVR is more than 90%. So if it's 90% LVR, the mortality is 90%, but not. But once you find the hydrocephalus, please survey the spines. 30% they're associated with the spinal defects, that is meningomyelocele. Why I'm saying spine survey? Because you find this spinal pathology as well. Again, that becomes incompatible. Look at the hydrocephalus, look at the large complex cystic area at the back of the spine in the lower lumbar spine. If you find this pathology and this pathology, it is incompatible. One catch point for the gynecologist over here, this BPD is more than 13 centimeter. And you know what is normal BPD of a lady full term? What is normal bipolar diameter of a full term lady? Shower 9.5. And it is 13, 14 centimeter. So cannot deliver normal. Okay? So please, the take home message over here, for those who are gynecologists, they can put a small needle or a cannula, decompress it, aspirate all the amniotic fluid, all the hydrocephalus, and then you can pass it on. Or you can send to the radiologist, they can put a small needle over there to decompress it and make it less than 7-8 centimeters so that easily this can pass through the vagina. Because baby is not compatible. Why to go for C-section? जब पता है मैं रह भी नहीं सकता, compatible life नहीं है, lethal है, so better is don't give a scar mark, don't give a surgical mark over there. Similarly, you can see this meningomyelocele. If you find only meningocele, that's a good catch point. If you find only meningocele, there is no brain tissue into it, that has got a very low mortality. अगर brain ठीक है, spine ठीक है, spinal bifida एक है, और only cystic area over there, that means it is surgically correctable. But before you make a diagnosis, you must survey the whole brain, you must survey the whole spine. Similarly, you can see these kyphoscolioid deformities, spinal bifida and spinal dysraphism, again incompatible. But sometimes you find the brain hemorrhage. How you appreciate that? Large, thick debris fluid, and once in the brain, you can appreciate it. Shift the million to the opposite side. Haloprocephaly, again that is incompatible with life. There are three varieties, A lobar, semilobar, lobar. The diagnostic sign is you find monoventricle. But very carefully, because in earlier days you can miss it. You can find the thalami diffuse. There's a large cystic area or a small cystic area in the midline. And you don't find the brain over there, you go find periphery. And look at this. And now you can appreciate even the brain tumors, large, rich blood flow, incompatible. Bas khatam ji, finishing ji. Arachnoid malformation, again. MSK, just last few slides. You must appreciate the normal spines, and you must appreciate this spina bifida. If the bones are small, again lethal question, muscular dysplasia. If the bones have got four things, number one, they are more than 6 weeks small. Number two, the bone density is disturbed. Number three, there is bowing. Number four, there is fracture. Number three, widening of the distal ends. If it is there with parahypoplasia, this is lethal and incompatible musculoskeletal dysplasia. And along with that, you can find the club foot. You can find the club hands. You can find the club feet. Agents of kidneys. Last slide. You can appreciate the urinary bladder grossly distended, and you can see bilateral gross adenomyosis. Cervical teratoma. Large cystic mass. This lady can never deliver normal because the neck is like this. You can only deliver if you are head down. बुढ़ापे में head down होता है, पैदाइश में head down होता है. Only in the younger age group you have the head. If you have this kind of presentation, you cannot deliver normal. And cephalocele, I just told you that. Teratomas. So my take-home message is, you can do this genetic sonogram by 14 weeks, but detailed anomaly scan is at 18 weeks, and associated anomalies should be look for that to diagnose the prognosis of this congenital anomalies. Thank you very much for that, please. If there is any question.